We have Roberta Butler. She is the Perinatal Hepatitis B coordinator in Kentucky's immunization program. And I'll turn it over to you, Roberta. Thank you.
Hello. Thank you so much for inviting me to speak today. I listening to the others. There a lot of what they have said is I have similar experiences with. So I think it kind of sounds like a lot of the challenges that we see are very similar. So I have been with the Department of Public Health as the perinatal hepatitis B coordinator for almost 2 years now. So we'll kick this off. Go on, change it. Next. Okay. So Kentucky law mandates that all pregnant women are screened for hepatitis B surface antigen during every pregnancy. For those with positive results, uh, they they are required to report that to the county of resident that the mother lives in and to the Department of Public Health within 1 day. High risk mamas who tested hepatitis B negative uh, and mothers of unknown statuses, though, they must be tested at time of admission to the hospital for delivery. Next. Kentucky, just looking at it across the state, 46% of Kentucky counties are categorized as maternity care deserts. Uh, that's higher than the national average of 33%. As a young mother, I can relate to this because my birthing hospital was over an hour away, and because it was so far, um, at that time, the county health department, the provider would come and see patients there. But that was still a 30-minute drive to get to that health department to be able to be seen. So, it is challenging. 72 of the 120 counties in Kentucky lack dedicated OBGYNs. 31% of women have no hospital within 30 minutes compared to the national average of 10%, and 14.3 of women who receive inadequate prenatal care, but that is a little bit less than the national average of 14.8. Next. So some of the challenges that we have that I noticed when I come in was that we had limited providers that were reporting prior to delivery. We have limited access to the communication systems that caused outreach and educational gaps between the providers. Um, Inconsistent identification of exposures before birth from the Department of Public Health, and there was no standardized process for access to hepatitis B lab results with pregnancy-related ICD-10 codes, and we needed stronger collaboration with the birthing hospital for timely reporting and intervention. Position changes in the state, coordinators, or the local health departments that presented some challenges to the program. Um, Inconsistent case management training and communication and collaboration with those, the health departments that was a challenge. Another thing is the completion of the post-vaccine serology testing. You can get the parents if we can get the series completed. It was just really hard to get this. Still is to get the PVST completed and collected. And then 58% of our families have language barriers, so that's very challenging. Now, I noticed that from January 1st of 2024 to March, that only 13% of exposures were reported by the OB providers. So that early identification of the hepatitis B exposures, that's so important because you can start initiating case management, get to know the families, help walk them through and let them know what's expected and what it is, education, education, education. Um, the local, we also had issues with not pulling labs from our NED system and the assessment of the ICD-10 codes associated with pregnancy. Um, there was very limited established relationships with the birthing hospitals. One of the first things I did when I came into this position was to reach out to every birthing hospital. And I think I found three that had actually quit delivering babies. So I just wanted to get contact information and, and let them know who I was and what I was there for. So, that was one of the first things that I did. Um, and then, like I said, we've had some issues with getting the PVST done. And some of the things that I've noticed is that, we could get maybe the provider would order the hepatitis B surface antigen, but not the antibody. So, you have a hard enough time getting the parents in to get the test done, but then here they have to try to get them back in again for another stick, and that's really unfortunate. So there's a lot of, just trying to re-educate and you know, trying to get the mommies to, if they understand the process, they're going to really, they want to advocate for their babies. So that was it's just really important that I can get some early establishment with these moms so that we can really empower them to be to know what's happening and why we're doing this and the importance of getting these done. Next. So, talking about birth dose specifically, we reviewed EPID 399s from one birthing facility. And it showed that approximately 30% of the infants did not receive their birth vaccine at birth. Um, Statewide, that raises up to about 50% that do not receive it at birth. Follow-up review with these infants did not receive the birth dose showed that 10%, a lot of them we were finding that they were saying they wanted to do it, wait until their first provider's visit. But when we went back and looked at it, 10% didn't get their vaccine their first 3 months, but also across the state, 10% of the infants did not receive it in their first year. So, it's really important, like some of the other girls said, to get them, you know, really find out their reasoning for saying no in the hospital and really educating, because, if you have these mamas that have transportation issues that, a lot of what we experience here, they're migrants. And so they're having, they have language barriers, they have transportation issues, or they may have multiple children. And so, trying to get to the doctors is a big deal because they don't have somebody to stay home with their other children while they go. And this language barrier is so big because, like, I noticed that some of our providers' offices do not draw labs. So they'll say, "Well, go down to the go down to the first floor." And to a mom that is a language barrier, that's overwhelming to have to try to maneuver through a clinic, go downstairs, and they might not be able to read those signs to get to get to the lab. And so, one of the things that I've really been working on is saying, if you don't, I always ask, the first thing is, do you draw labs in your office? And if they say no, we send them down the street or we send them downstairs. I'm like, if they're just going downstairs, please send somebody to go with them, escort them down there, make it easier for them to be able to get to that location and tell them what needs to happen so that because that language barrier, it's just overwhelming to a mama. And it's overwhelming, especially if she has other children with her, to round them all up and try to figure that out. It's just, let's make it as easy as we can to make this go as smoothly as possible. Um, So, in a review of a preliminary 2024 data shows, though, that 67% of infants born in Kentucky does receive their hepatitis B vaccine. Next, please. So, in review, the majority of these that declined is they want to wait for their first visit with the provider. So you can see the different responses here that they said. And next, please. Okay, so our goal is to we need to take our 50% to 90% in order to meet our Healthy People 2030 target, and to ensure that our babies, our little Kentuckians, are protected. So we found two groups that, the majority of them, it wasn't the anti-vaxxers, they were the minority of the group. It was mainly they just want to wait. They don't see the need to have that first shot right at birth. Nobody wants to poke their baby, their newborn. So, some of the successes that we have had to try to make this easier is we've partnered with our MCOs to create a provider list for distributing educational materials and updates. We have developed hepatitis B toolkit, pamphlets, mandatory reporting letters to remind the providers that needs to be done. So I'm doing that in time. If I find out that mommy is positive and I did not hear from that provider, I'm sending that mandatory reporting letter straight to the provider to re-educate, to let him know it's expected. And then we have lost to follow-up letters if we have those that we lose that we just cannot find. So we'll send that to the provider as well, letting him know if that patient shows back up, please make sure this is done. We're doing grand rounds, and additional trainings is in the development right now to go into our Kentucky train so that these providers can be, re-educated and continuing education. So through our enhanced case manager training and increased provider and parent education, our closure of exposures that completed the post serology testing increased by 33% from birth year 23 to 24. Next. We created reports to extract hepatitis B lab data for ICD-10 codes from NEDS. We've started quarterly meetings with the birthing hospitals to collaborate and educate on the hepatitis B care and expectations and educations and immunization hesitancy and just, how to educate and question. And we've also implemented quarterly meetings for the local health department case managers to improve coordination there. We developed a REDCap database for better documentation, and we provide on our meetings REDCap training for effective use. And so this has really, really helped, and I'm excited to see how this year progresses because our hepatitis B exposure identification before birth has increased from 42% to 68% with the REDCap. And has improved early intervention. Next. And that's it. Fast, sweet. Thank you. If anybody has any questions, just post them in the chat and I'll try to answer them.
Thank you so much, Roberta. I loved hearing about the challenges and the successes and the ways that you're really improving your program. And it's excellent that you're already seeing those results. So congratulations to you. Thank you for sharing.